Hello everyone, hope you're having a great day today. So we are talking about chapter 20. It's special populations, and today it is programming during pregnancy and postpartum. So here we go. Pregnancy is associated with multiple anatomical and physiological changes. Originally, prevailing opinion was that physical activity should be discouraged during pregnancy because of the supposed increased maternal and fetal risk of untoward events. However, current research suggests that unless a specific obstetric or medical condition is present, the likelihood of adverse events or complications following acute exercise or chronic training in the mother and fetus is minimal. The fitness professional should recognize that, similar to other populations, physical activities in people who are pregnant and those in postpartum period confer numerous benefits and should be encouraged. Collectively, the fitness professional, the client, and obstetric health care provider can establish the following exercise program goals: avoiding excessive weight gain, reducing the risk of gestational diabetes, and lower the incidence of low back pain, and prevent excessive decreases in cardiorespiratory and muscular fitness. Prior to participation in an exercise program, pregnant women, regardless of physical activity history or lifestyle, should be evaluated by their obstetric provider to determine whether exercise is contraindicated. Having pregnant clients review the physical activity readiness medical examination for pregnancy, or PARAMED X for pregnancy questionnaire, with their healthcare provider is recommended to help determine the appropriateness of participation in a fitness routine. A PARAMED X for pregnancy questionnaire should be signed by the obstetric provider to verify the safety of exercise and provide recommendations for cardiorespiratory and resistance training activities. Personal trainers who work with pregnant clients must be knowledgeable of and able to educate clients on the potential signs that would warrant the termination of exercise, such as vaginal bleeding, regular and painful calf pain or swelling, amniotic fluid leakage, dyspnea prior to exercise or shortness of breath, dizziness, muscle weakness affecting balance, calf pain or swelling, headache, or chest pain. Fatigue, nausea, and vomiting may limit exercise, especially during the first trimester. Importantly, the fitness professional should recognize the increased nutritional requirements of pregnant clients. Fitness professionals are encouraged to utilize the metabolic calculations presented in Chapter 15 to estimate the total energy expenditure of the client's exercise program. Pregnancy requires approximately an additional intake of 300 kcal per day to fulfill the increased metabolic demands of pregnancy. Pregnant women have diminished thermoregulatory control throughout pregnancy. Consequently, they need to be counseled to maintain adequate hydration, wear appropriate clothing that will facilitate heat dissipation, and avoid exercise in hot and humid conditions. Women should be encouraged to choose environmentally controlled indoor settings in these situations. Lastly, the fitness professional should remind clients that pregnancy is not time to expect large movements in fitness and ultimately throughout the gestational period. It is normal for numerous fitness parameters to decline. The physiological changes associated with pregnancy persist for 4 to 6 weeks postpartum. However, women typically can gradually return to exercise provided the delivery was uncomplicated. Women who are nursing may elect to feed their babies prior to exercise to alleviate the discomfort of engorged breasts and to reduce the likelihood of feeding problems post-exercise due to acidity in the breast milk. The general cardiorespiratory training principles of exercise prescription detailed in Chapter 15 apply to pregnant and postpartum women, although the profound anatomical and physiological changes will require the personal trainer to make a number of special adaptations to the training program. Table 2010 lists some of the exercise modifications for pregnancy. The consensus statement for regular physical activity from the U.S. Surgeon General as 30 minutes of moderate intensity physical activity on most, if preferably all, days of the week is an appropriate target aerobic exercise program for most women during uncomplicated pregnancies. Recreational and competitive athletes may train safely at higher intensities and volumes throughout pregnancy with the understanding that they are undergoing close obstetric supervision. The general resistance and flexibility training principles of exercise prescription detailed in chapter 14 and 16 with several adjustments that account for morphological and physiological changes apply to pregnant and postpartum women. After the first trimester, resistance and flexibility training exercises in the supine position should be avoided because of the potential obstruction of venous return and subsequent risk of orthostatic hypotension. Isometric or heavy resistance training may elicit a pressor response suddenly with a sudden increase in heart rate and blood pressure and is not recommended. Joint range of motion will be enhanced during pregnancy because of increased circulating levels of relaxin, and therefore the potential exists for ligament and joint capsule damage with an overly aggressive flexibility program. Consequently, fitness professionals are encouraged to focus on maintaining normal joint range of motion with slow, static stretching throughout pregnancy. And this concludes part 2 of chapter 20 of special populations. Thanks for joining me today. I'll talk with you soon. We'll be looking at part number 3 in just a few moments.